So we're going to set up my slides next. As we're doing that, because we are talking about physical activity, please stand up. Right? We are a chair-loving society, but you all actually are not chair lovers. You are sort of forced into this. Your environment is forcing this for you. So you've just, congratulations, moved from sedentary to mild physical activity. Well done. Feel free to fidget. Please have a seat. I am delighted that I have the opportunity to talk with you today about physical activity and pediatric obesity prevention, and really I think our charge, which is how do we put the science to work. So I'm going to focus on the preschool period. And before I do that, I'd like to ground you in what makes preschoolers unique. So when you look at preschoolers, raise your hands if you have preschoolers in your life. If you see preschoolers, raise your hand. Anybody who's been to the airport recently has seen a preschooler. Yes, all right, so that's 100% of you. The main thing that you will notice as you're watching preschoolers, first about their growth and adiposity, when you're 2 and 3, you're chubby. And in fact, it looks like you've got this nice, cute, chubby center. Nobody would call it visceral adiposity at that time. We would just call it being a preschooler, 2 to 3. Now what happens from 2 to 3, and usually from the ages of 4 to 6, and sometimes all the way to 7, is that you grow up, you sprout up. And you heard Kathy talk about this as tempo and timing. It's different for every one of us, and it's called saltatory growth. I can't predict when it's gonna happen for your children. I couldn't predict when it happened for mine. So here he is 7, so if we move from 3 to 7, he sprouts up. It's actually quite important that your height velocity is much higher than your weight velocity. That is normal growth in the preschool period. So raise your hand if you've seen this BMI chart for children. And looks like about 80% of you. What I'm going to really focus your attention on is this dip. So this is non-linear growth. And children emerge usually around 6 or 7 from this non-linear growth pattern to a linear growth pattern. It's really quite important to understand this because I'm about to talk to you about interventional studies that have been done. And if I look at only pre and post BMI, I might be confused about whether my study worked or not. So let's say I am 3 and I enter the study, and here I'm at the 95th percentile. That means I'd already be obese. And I'm 3, and you can see my BMI here is more than 18. And then I measure again when you're 4, and now, wow, my study must have worked. My BMI is 18. So that is not true. This is why it's so important that you understand growth and adiposity and what does normal look like in this preschool period. So I also want to ground you to the fact that you've got a huge range of normal. Normal looks different. There's not one way to look normal or healthy. And so when we talk about this for preschoolers, you're between the 5th and the 85th percentile. All of that's considered to be normal, giant range. As soon as I get to that 85th percentile, that's considered to be overweight. From 85th to up to the 95th, greater than or equal to the 95th, is obesity. So I wanted to ground you in that. You are not supposed to grow linearly when you're in the preschool period, and this is really important. Now, while we might be a chair-loving society, our preschoolers are not. In fact, we have to force them to sit down, don't we? Preschoolers and children are meant to move. We are too, but they are meant to move so much that they know it, and they will move all the time. But how they move is different. And so I want to ground you now in how preschoolers move. What's physical activity look like in preschoolers? So what we did was we put accelerometers on all of our children. They wore them like princess belts or superhero belts, and they wore them for almost 24 hours a day for 7 days. It picks up muscle movement every second of every day. And we assessed what did these patterns of physical activity look like. Not only did you achieve your 60 minutes of more of MVPA, but what does that look like in a preschooler? And we used the validated threshold by Pate et al. So on average, our participants wore their accelerometers for 23.4 hours a day. That's huge in the literature. Usually minimum wear time is 6 hours a day. This was considerably more, and it allowed us to ask and answer different questions. Children spent 14.5% of their awake wear time in MVPA. And you might say, wow, that doesn't sound like a lot. But actually, we spend between 10 and 20% of awake wear time to be healthy, and all of the correlational studies show you that it's not you're supposed to be physically active every minute all the time for all of your awake wear time. So we weren't too surprised that that was 14.5%. There were 50 children that participated. They were all from underserved communities, 50% of whom were African American. 74% of them were normal weight, and 26% of them were overweight. None were obese, and that was by design. So raise your hand if you've seen this type of output from accelerometry. That is about 12% of you. And so for the rest of you, what this means is you get these muscle movements and these ticks in time. We use these validated thresholds by Dr. Pate and many others, but I always use his because he really has focused on the preschool period, and preschoolers are different. So as soon as you get to this red line here, so red and above, that's what we call MVPA, moderate and vigorous physical activity. It's not to say that there isn't another type of activity. There's light physical activity. I'm in it right now. This is probably going to be the greatest amount of physical activity I get right now. And so that's between here, this yellow line up here to this red line. And you can see this gives you sort of a quick snapshot. You're sleeping here, so there isn't a lot of movement. And you can see when children are waking up between 6 and 7, they start to ramp up. You can see these patterns of when they have spikes. Now here's the thing that surprised us. We found that all of our children achieved MVPA, and in fact, on average, more than 100 minutes per day of MVPA, but it took them 11 hours to get it. 11 hours. So that means young children are active throughout the majority of their waking day, but they're not like us. They didn't go to the gym for 30 to 60 minutes and now they're done. It's happening all day long. And what we found is that there were 4 different types of physical activity patterns. The first type here we called an isolated spurt. It meant you had less than 1 minute of MVPA followed by preceded and followed by periods of quiescence. The example of that is I'm running to my parent. The second type is isolated sustained activity. So quiescent preceding, then you have more than a minute of MVPA, and then you have complete quiescence. So an example there might be running after a dog in circles over and over, and then you just get tired and you stop. The third type is what we call a clustered spurt. So you have quiescence, then you have this brief burst that's less than a minute, then you have a little rest, which is less than a minute, then you have a brief burst, which is of MVPA less than a minute. So an example here could be red light, green light. The last category that we noted was something we called clustered sustained activity. So now we have sedentary followed by MVPA for longer than a minute, brief period of rest for less than a minute, and then a longer period of activity. So that could be a chasing game. You remember playing tag and you have to run to base. Kick the can is a great example of clustered sustained activity. So we saw these 4 patterns. Now what's interesting is that both boys and girls, preschoolers, achieved that goal of more than 60 minutes. Our average was 110 minutes of moderate to vigorous physical activity. Took them 11 hours to get there. And girls, more often, they got there through those quick isolated spurts. But boys, they got there more often through these clustered sustained activities. How they were physically active, not if, was different. So when we look at the daily events of each MVPA category, both boys and girls participated in all of these types. But you can see for the daily events, it was really largely through these isolated spurts, which lasted 1/3 of a minute, and through this clustered spurt, which lasted on average 3 minutes to get to that MVPA. So why does this matter? You can see that if we're structuring our day so that I give you structured time to play, I'm not going to be able to capitalize on normal development. So this is important and I think should shape how we think about programs and policies. But I'm going to build the story from here. So girls, more isolated spurts, boys, more clustered sustained activity, but both participated in all 4 types. All right, so now you know how preschool children grow non-linearly. You know how they move in spurts and sporadically. So now let's look at interventional trials. So we're looking at something called a randomized controlled trial. Raise your hand if you've heard of that before. Not everybody, don't laugh. So about 50% of you have heard of it. Something that's important about an intervention trial is that we're always trying to create a comparator group to understand, did the intervention actually work, or would another group who wasn't exposed to it just by randomness or something else that's happening, like Let's Move is now happening in the school, would that group have increased just as much? So having a control group is critical. I'm just going to highlight here in the school setting 3 specific studies. The first one here was Nyberg, and Nyberg looked at the effectiveness of universal parental support program to promote healthy dietary and physical activity in 14 preschool classrooms in Sweden. Most of the children were normal weight, total of 243 children participated, and classes were randomized. So they either got parenting support and education, or they had 10 teacher-led classroom activities for 6-year-old children. Now the activities could be didactic, or they might be physical activities, and they occurred over 6 months. There was no significant intervention or effect in physical activity or BMI. And so now that you've heard all of the preceding talks, and I think Kathy really highlighted this importantly, you're going to be asking some questions. You're going to not say, oh, I guess it didn't work. You're going to say, what was the duration of that physical activity? What was the intensity? How did they actually measure physical activity in MVPA? All good questions. So I'm going to bring you now to the next study by Resnick et al., also a classroom-based physical activity intervention for urban kindergartners and first graders. School-based in 2 schools in New York. You can see here more of those children were already overweight or obese, but about 50–60% were normal weight, and close to 1,000 children participated. The intervention included audio CDs of 10-minute education focused on aerobic activities led by teachers 3 times a day for 8 weeks. That's good. Now I know that it's aerobic, so MVPA, I know the amount that they were exposed to. And what they saw was that the intervention group students had an increased number of steps, so they used pedometers. They had about 300 more steps than the control group, and that it was equally effective in gender, grade, and BMI subgroups. So it was also a pre-post, baseline versus 8 weeks later. So now you're thinking, 8 weeks, that sounds kind of short. What about a longer duration? And for that, I'd like to highlight some of the work from Nemeth et al. So Nemeth was looking at Arab Israeli kindergartners, 340 of them, ages 4 to 6, 71% were normal weight. And what they did was they taught teachers nutrition and physical activity programs through existing curriculum. And the physical activity included 45 minutes a day, divided in 3 15-minute sessions. That sounds pretty consistent and good compared to what I just described to you about how preschoolers move. 6 days a week. They only rest on the Sabbath, but they go to school every other day. 80% running games, 20% endurance activities. This was MVPA. What they found was that there was a change in BMI percentile in the intervention group of 16 percentile points. That's clinically significant. I'm a practicing pediatrician. And the control group actually increased their BMI percentage over that year period. They also saw that there was a change in fitness levels at the end of 1 year. And they used something called a shuttle run lap test. Raise your hand if you've ever heard of that. Wow. More of you know that than a randomized controlled trial. Great, okay. So the idea of this test is that you're running from cone to cone. Instead of 20 meters, they changed it to 10 meters. These are preschoolers, and you have this beep that's emitting, that's telling you how fast to run. And just the way our activity break did this, where you had to do this really quickly all of a sudden, and you weren't sure how fast to do that, they do the same thing there with the audio. And they found that fitness increased significantly for the intervention group. More importantly, they looked a year later. What happened a year after this intervention? Was there any sustainability? And they found, yes, indeed, there were 2 very important findings that were sustainable a year after this study ended. The first was that there was a long-term effect on fitness. So you can see that this is now 1 year after the study ended in the black bar. And what you're going to notice that is in both the control and intervention group, there's a little bump goes up on both groups. But what you'll see from the intervention was that there was almost a priming effect immediately after the study ended, and that it was sustained and even went up a little bit more 1 year later. That's really exciting. Also, you can see that in addition to improving fitness, they sustained the changes in BMI percentile. So it was sustainable. So what we've done so far is we've talked about how preschoolers grow differently in a non-linear way, how they move differently in sporadic spurts, and it takes 11 hours, that you can have school-based interventions, and that as long as you have dose, duration, intensity, that there are some really promising findings that can even be sustained a year later. What if we take this and we move this into other community settings? So I'm very fortunate. I'm from Vanderbilt. That means I'm in Nashville, Tennessee. That's why I'm wearing my boots, which I can still exercise in. And I arrived at Vanderbilt in 2006. And at that time, our then mayor, Bill Purcell, had arranged for me, he didn't know it was for me, a natural experiment. He had doubled the number of parks and recreation centers, and he had put them in urban, dense areas, many of whom had not had that geographic access to that type of built environment that could support physical activity. And so we thought we would put that to work to see how are people using their recreation centers for physical activity, and how could we promote that type of use for sustained routine physical activity in early childhood. So we were funded by the state of Tennessee and the Vanderbilt Institute of Clinical and Translational Research in 2008 to 2010. We wanted to test a family-based, community-centered intervention to prevent and treat obesity for Latino parent preschool child pairs. We enrolled more than 100 Latino families with preschool children in a 12-week session. The sessions were all about skills building because we found that almost everybody already knew. They knew they should be physically active. They knew they shouldn't be feeding their children high fat, high sugar. They should not be giving children Coke. They already knew. What they needed was the skills to match their contextual circumstance. I have $10 in my pocket. I have to feed my children. What do I do? That's a skill. I have this new recreation center in the community that I never thought was for me. How do I use it? So we focused on dyadic skills building, and our goal was not only to improve the outcomes in children, but also the participating parent, because preschoolers live in the context of their families. And we're going to talk about how that's an especially important amplifier. The control group was to promote school readiness, and we worked with our library system to do that. And I'm going to briefly go through this slide to tell you that they were preschoolers, that they were by design. You can see their absolute BMI here. You now know that doesn't tell you much because preschoolers grow nonlinearly. So you can see here that about 40% were already overweight or obese, very consistent with what you heard Kathy tell you. You can't wait until school age. You have to start earlier. The parents had a mean BMI of 30 and their waist circumference of 100 centimeters, which means they had visceral adiposity. The majority did not have a high school education. The other key element is we had parents wear these accelerometers too, and it might not surprise you to know that about 80% of awake wear time for parents was absolutely sedentary. You all are doing a good job with that too. Please remember to fidget to bring you to mild physical activity. But what surprised us was that 70% of awake wear time for the preschool age children who are built to move was also sedentary. So I really have to go fast, and I want to hit a couple of key points. The first is that we found that 12 weeks later, this made a really big difference. The children who started in the obese category moved to the overweight category twice as much versus the control group, and if they were overweight, they moved into the normal weight category twice as much as versus the control group. So this seemed to work, and why did it work? Well, families were starting to use their built environment for physical activity, and not just the the child, but the parent with the child. So I am at 0 minutes, but what I would like to emphasize is that we know that context and environment makes a difference. And so here, these are GIS maps, Geographic Information System maps. It's showing you part of Nashville, Cumberland River, Northeast Nashville, South Nashville. If I only showed you crime rates, you might hypothesize that parents do not send their children outside to play in Northeast Nashville more than South Nashville. But that's not true. They equally don't send their children outside to play. And I have to tell you that Mayor Bill Purcell and now our current mayor, Carl Dean, have been incredible proponents of safe, green spaces and parks and rec and making it accessible. Why are they not sending their children outside to play? Anybody? I heard time. Safety, well, so we've talked about crime, could be traffic, lighting, speed, absolutely, it could be all those things. But what we learned is that it was stray dogs. This is a map of stray dogs, and this shows you that it's much worse in South Nashville, and it's much worse in the gradient of 4,000 stray dogs in the red zone versus 40 stray dogs in the green zone. So the good news, and I told our Mayor Dean about this, is that we already have a policy on the books. We already are paying people to address this problem. Now we need to enforce it. So I have to quickly take us to my final slide and let you know that while we might not be able to immediately change the stray dog problem, what we found through a grant from the Robert Wood Johnson Foundation is if we taught families the skill about how to use their built environment, parks and recreation in particular, that a year later, they continued to use it, and 50% of them were using it more than once a week, and parents were bringing their young children for sustained, routine physical activity, and that's how you improve health outcomes. So my conclusions are fourfold. The first is physical activity patterns are spurt-like and sporadic in a preschool-age children, and programs and policies need to consider how to align with this developmental stage to reinforce these early MVPA patterns. The second is that families with young children benefit from being taught the skills to use their existing built environment. You don't just build it and they come. You build it and then you teach them how to use it and then they will come. The third is to use the existing built environment for regular physical activity is influenced by perceptions. So if I still think there's a stray dog problem, even if there isn't, I'm still not going to send my child outside to play. Subjective perspectives matter. And the fourth is routine physical activity for children is influenced by parental activity. So don't think about this as one child at a time. Think of this as one family at a time. Thank you very much.